Everybody, and good afternoon. And I mean, first of all, I think I would like to say how much I welcome the fact that Healthcare Improvement Scotland have organised this event. I think it's great to see the level of interest in the topic, and I do hope it is the beginning of a further discussion. So, if you move to the first slide, please. So I'm here because I was a member of the executive team of the Scottish Mental Health Law Review, which was led by John Scott KC as he was. He's now a judge, and we reported in last September with a report. The one thing that everybody knows about the report is that it's 1,000 pages long, and I worry that that means people are frightened of reading it. I mean, I'd encourage people to read the 1,000 pages if they really want to, but they don't need to read all of that. I mean, I think even reading the list of recommendations or the executive summary will give you a sense of the review. And if we go back to why are we doing this review, why did we do it in the first place? Well, part of it is about the fact that mental health law and capacity law, because the review also covers adults with incapacity, is over 20 years old. A lot has happened in that 20 years in human rights, increased emphasis on the Convention on the Rights of Persons with Disabilities. There have been changes to care and practice. And there have been issues that have arisen with the operation of the legislation, which meant that it doesn't always work the way that Bruce Millen's committee thought, I think, when they set the review up back in the early 2000s. So a lot of recommendations in the review, but three very clear themes running through: strengthening the voice of people who use services and carers, reducing the need for coercion, and securing the rights to the help and support needed to live a good life. So you see that coercion in mental health care is an absolutely fundamental part of the review, and reducing the need for coercion is core to whether or not the review will be a success. This is a slightly teasery kind of time to be talking about this because we're waiting on the government response. We understand the government are going to be responding next week to the review, although I don't think at this stage they're going to be saying, you know, we accept recommendation 1 and we don't accept recommendation 2. I think it's more a general indication of how they're going to deal with the approach of the review. I think it'll be broadly supportive of the approach of the review, and it will recognise that this is going to be a long-term change programme. It isn't a case of just saying we're going to bring in a new act and everything is going to be sorted. That changes in legislation will need to go alongside changes in culture and practice, and that will have to be driven by people like the people in this meeting. Next slide, please. So what do we mean by coercion? Well, these are a few of the things, the bullet points are a few of the things that we understood coercion to mean. We did spend quite a lot of time actually in the chapter, and there's an annex of the report trying to define what we mean by coercion. And it was a sensitive topic. Some people didn't like the word at all, didn't like the idea that we were suggesting that people use coercion. People would sometimes say, well, coercion is not what we're about. Coercion is a bad thing. We're trying to help people and support people. And that's not what we were saying. We were not trying to say that people who use coercion are always wrong, or that coercion is always a sign of ill intent. But we do, and also we don't think coercion is just the most obvious and intrusive interventions, such as it were, physically restraining people, tying them to the chair or something like that. The coercion can happen even when powers are not overtly used. I think Claire's going to say a little bit more about some of these kind of concepts around coercion, but I think some of the things that we do think it's important to hang on to in mental health care is, firstly, the people working in mental health care are unusual because they do have, and particularly doctors, but also other professionals, have legal powers to require people to do things that they may not want to do, and those are powers that other professionals don't have, and they only apply in relation to people with incapacity or mental health issues. So the fact that it's a unique setting is important, and means that the safeguards are extremely important. It's also important to recognise that there is, particularly in institutional care, a power imbalance between professionals and service users. And as I say, we do not say that coercion is never justified. It's not always wrong. But even where coercion is justified and is appropriate, we think it should be understood as a harm. It's something that causes harm. It, as a minimum, involves not treating people as autonomous subjects, and that's significant in itself, but it can also be extremely traumatic for the person and even for others around the person, and indeed can be traumatic for professionals as well. So it is a harm that we should be trying to reduce, even if sometimes it can be justified. Next slide, please. So I just want to say a little bit before we get into the recommendations about how we were informed by human rights, international human rights instruments, and how they've evolved. ECHR, the European Convention on Human Rights, has always been an underpinning, certainly since the evolution of the law and practice in Scotland, and certainly of the 2003 Act and the Adults with Incapacity Act, that has specific provisions relating to coercion, particularly Articles 3, 5 and 8. Article 3 is the absolute prohibition against inhuman or degrading treatment, and that can never be justified. But also Article 5 is around detention, which can sometimes be justified, and Article 8 is about interference with people's bodily autonomy, and that can again sometimes be justified. ECHR accepts that what they call being of unsound mind can be a justification for detention of some kinds of differential treatment, but has increasingly evolved to strengthen the safeguards against arbitrary detention. There's been less case law around Article 8 and interference with autonomy, which touches on issues around restrictions on people's liberty. But it is an evolving field, and it is something the courts are increasingly looking at as a means of challenging the power of people to force other people to do things they don't want to do. So ECHR is still with us, but we've also now got the UN Convention on the Rights of Persons with Disabilities, which has increased in significance and may increase even further because the government has just issued a consultation on introducing this and other UN conventions into domestic law, so it would have similar status to the ECHR. But even now, it is something that we need to take into account. One of the differences between CRPD and the European Convention is that the CRPD's approach, the whole approach, is based around challenging discrimination and ensuring that people with disabilities have the same rights as others to have their will and preference respected and have their autonomy respected. So it's already in tension with the European Convention, because the European Convention does, to some extent, argue that having a mental disorder justifies different treatment to some degree, or at least could be a partial justification for different treatment. The UN Convention challenges that. And the UN committee that supports the implementation of the UN Convention has taken an even stronger view, and it is said in terms that mental health laws that permit forced treatment need to be abolished. We need a completely different and non-discriminatory legal regime. And we looked very hard at that in the review. In the end, we concluded that we couldn't go quite as far as that in our approach, that we didn't think you could argue that force could never be justified, and we didn't think that taking it out of the law would necessarily benefit people. It might just mean that things happened without legal safeguards. But we did look carefully at another UN document, which is a report by a guy called Dionysios Pouras, who is the UN Special Rapporteur on Health a few years ago. And he called for what he called a full spectrum approach to reduce the need for and use of coercion in mental health care. And he had a list of things that he said needed to happen to make coercion, perhaps working towards abolition. We may never get to abolition of coercion, but certainly significant reduction on the use of coercion in mental health care. And in the review, we were encouraged by evidence from around the world that there are things you can do to reduce coercion. It's just that we haven't done them all in a concerted way. Next slide, please. So, I mean, the coercion chapter, which is chapter 9 of the report, I suppose splits into two broad things. One is around the broader approach to reducing coercion. We think that law on its own won't be enough. One of the things I reflected on from my time at the Mental Welfare Commission is it's relatively rare, I mean, not unheard of course, but relatively rare to come across a situation where you say that coercion should never have happened in the circumstances that it did. It was much more common to say, well, that coercion perhaps was necessary in the situation that people found themselves in, but there were things that could have been done much earlier than that might have prevented the need for coercion arising. And there might be things that can be done after that to prevent it from arising again in the future. So if we're serious about reducing coercion, we think you don't just look at the regulation of individual episodes of restrictive practice. You go further upstream and thinking about alternatives, particularly to emergency and crisis interventions. And chapter 9 discusses in some detail the kind of things we think could help, like peer and community support, different kinds of crisis services, new models of trauma-informed service, and so on. So I mean, we're not saying these things don't exist, they do exist, but they're very patchy. We did look at some international examples where people have reasonable evidence of having been able to reduce the need for coercive interventions by different forms of care. We didn't think it was our job or our expertise to propose a particular model of care or support. We set out lots of examples of things we thought would be worth trying, but we think this is something that needs to develop in Scotland with professionals and with user involvement in the heart of developing an improvement programme to reduce coercion. Again, that's not to minimise a lot of the good work that's been done already and things like the Patient Safety Programme, some of the work of the Mental Welfare Commission on guidance, some of the work around the development of mental health service standards and so on. But I suppose our take on the Patient Safety Programme was it felt like a bit of a coalition of the willing, that people who were interested in doing things to reduce restrictive practices or to make them more rights respecting would get involved in those things, but it was quite small tests of change sometimes, and it wasn't obvious to us that that was being mainstreamed across the system. So we call in the review for government to make this a national priority in mental health care. I know that the new mental health strategy is coming out soon as well. I mean, unfortunately, I suspect it was probably mostly written before our recommendation has been absorbed, but it would be great to see this in the mental health strategy as a key priority and something that feeds into the agenda of bodies like Healthcare Improvement Scotland, the Care Inspectorate, and Public Health Scotland, all the different national and local agencies. So it should be something a number of agencies, including the third sector and service user organisations, are working together on with clear shared objectives. And one of the other things that came through very strongly in the evidence we received is the need for systemic and transparent data at service board and national level that just doesn't exist around a lot of the restrictive practices that are that people experience at the moment. We also talk a bit about the experience of minority ethnic communities and other people who may be particularly affected by this. And again, with very poor data on the people with protected characteristics and intersectionality. So there's a lot needs to be done around data And we say there's a stronger role for the Mental Welfare Commission in all of this as a thought and practice leader, but it's absolutely not for the Mental Welfare Commission to do everything. It's for other people too. Next slide, please. But we do look at the law as well, because that was our job. It is a law review. And one of the things that we felt about, two things, I suppose, about how the law regulates coercion at the minute. One is that it tends to regulate or authorize coercion in advance of it happening. So a CTO would authorize giving medication by force if necessary. Guardianship under the Adults with Incapacity Act would authorize the guardian to restrict somebody's liberty, but it doesn't introduce protections when the thing actually happens, except for Part 16 of the 2003 Act, which covers, as people will know, medication after 2 months, ECT and other particular treatments, but doesn't cover things like restraint, seclusion, or covert medication. So we're recommending that we think about extending the safeguards in Part 16 to cover those kind of interventions as well, with greater oversight. And that also we look at the safeguards that have been brought in England, with what's called Senny's Law, the Mental Health Unit's Use of Force Act, which has introduced new safeguards or is introducing new safeguards in England. But we also think it needs to go wider than the traditionally understood mental health services. It's not just in acute wards. I mean, there are people being given restraint, being isolated, certainly being medicated in care homes, people with dementia, for example, who don't even come near the Mental Health Act. And we think safeguards need to be improved there. We had evidence from the Commission on the use of short-term detention and CTOs, that sometimes these things, people run out the clock with these kind of time-limited orders, and the Commission have suggested that, and we agree that time limits need to be reviewed. And we also recommend, and this is probably a longer-term thing, a more radical power for the Mental Health Tribunal, which would build on the appeal rights that already exist in relation to excessive security and forensic mental health care. That if people are in a restrictive environment, you should be able to challenge the level of restriction which applies to you. So I've run very, very quickly through what is a very long chapter of the report, and brought in a couple of things from other bits of the report as well. So apologies for shoveling a lot into a very small space, but I hope that's given people a lot to think about and to discuss as we think about how do we now respond and take forward the proposals of the review. So thanks very much.
Thank you very much, Colin. Like you said, there's a lot in that to think about how we start to improve these things and how to turn the kind of legal theory into practice on the ground. So up next we have Dr. Roger Smyth, who is a consultant psychiatrist in the Royal Infirmary in Edinburgh. And I'll hand you over to him to talk about non-consensual treatment and the Scottish Mental Health Law Review. So Roger.
Thank you very much, Jane. So I will begin by, Jane's already introduced me. I'm a consultant psychiatrist in the Royal Infirmary. The basis on which I'm speaking to you today is as chair of the Legislative Oversight Forum of the Royal College of Psychiatrists in Scotland. I'm going to briefly talk about the role of the Royal College of Psychiatrists in the part of the Scott Review dealing with non-consensual treatment. So when somebody these days is described as doing well, we say they're living their best life, living his best life, her best life. And that reflects the fact that one of the most important tasks we have as individuals is how to live our lives in accordance with our ideals and live up to those ideals. And the state, as just a big grouping of individuals, must take on this task too. It's the duty of a state to make sure that its laws reflect its values. And that's particularly true, particularly important for those laws affecting the care of people with mental illness. The Scottish Mental Health Law Review, what we've often called the Scott Review, it continues a process that's been going on now for centuries, when we, from time to time, examine our laws to make sure they meet up with our current understanding of the rights our citizens should expect. Next slide, please. And we in Scotland have probably been wrestling with these issues for longer than any other country. This is a quote from James Viscount of Stair, one of the famous institutional writers on Scots law, who gave the view in 1693, we may also, without any injury, restrain a furious person, or one who's inferring violence to himself in his life or limbs, because this is not against an act of his lawful liberty, but is done as a duty in us of love and mercy. He was understanding there a concept that we wrestle with now, that people have a right to expect lawful liberty and to be left alone in their person and in their possessions. But sometimes we, acting as agents of the state, and acting, we hope, lawfully and in line with good clinical ethical practice, might have to interfere, not against liberty, but as a duty on us of love and mercy. And once states began to prioritize liberty of individuals as the main focus of the law, since then we've had to wrestle with dilemmas of how to balance the right to liberty with the possible authority of the state to interfere, perhaps by force, or perhaps more often by the concealed threat of force, in the lives of those with mental impairment. And here we must consider first up, not the outcome we're looking for, but the rights of the due to the individual. Next slide, please. And this is the European Court of Human Rights, which oversees any kind of suggestion that there are breaches of the European Convention on Human Rights. And for the avoidance of doubt, the European Court of Human Rights is a body of the Council of Europe. It is not part of the European Union. We remain part of this body. And in fact, Britain was instrumental in establishing this court. And the Scottish Mental Health Law Review, as Colin's already told you, wants to include additional charters of rights in consideration of those rights, the UN Convention on Rights of Persons with Disabilities, the UN Convention on Rights of the Child. But the foundational rights in UK and Scottish law remain those described in the ECHR, the European Convention of Human Rights. And they're not just there in an abstract form in a court in Strasbourg, but they're also incorporated into our Human Rights Act and into our Scotland Act, the foundational document for our Parliament. And Colin's mentioned other rights already, but the court itself described that these first four rights, Article 2 to Article 5, are absolutely in the first rank of the protection of our citizens. Article 2, the right to life. Article 3, the right to be free of torture or human degrading treatment. Article 4, the right not to be held in slavery or servitude. And Article 5, the right to liberty and security of person. But as you see there, the first three are absolute, and Colin hinted at this as well. There's no derogations, there's no exceptions, but the fifth can be limited in some circumstances and with some justification. Obviously crime, for example, but also because of medical conditions, both infective and mental disorders allow for possible Article 5 compliant restrictions. And we all in this country and around the world experienced restriction of our rights because of legislation enacted to control infectious diseases in the last couple of years. But here we're talking about potential restriction of the right to liberty and the right to personal autonomy because of mental disorder. And a key issue for practitioners is how to balance competing rights. It's very easy to sign up for each right individually. But as clinicians, we come upon the issue where it seems that the only way to protect someone's right to go on living, or to protect their right not to be living in cruel and degrading situation, is to perhaps temporarily override their right to liberty by detaining them under the Mental Health Act. The key issue for practitioners that we brought to the table was not only how to respect rights, because we saw ourselves as being one strong voice in upholding rights, but how to balance competing rights when they were in potential conflict. And the Scott Review took views from all across Scottish society. Users, carers, and professionals of all types were involved to attempt to answer this and other questions. Next slide, please. And the number of people involved was way more than this, but the executive, which had 6 members, half lived experience and half professional, took input from a wide range of about 8 to 10 different working groups that were each tasked with a particular issue, whether communications, capacity, children and young people, AWI, and so on. And the one that I was involved with, that I'm bringing some reflections on here, was what we called at the time the compulsion group, but is down there as the involuntary care and treatment group. And as you see from the sum totals of the lived experience people, lived experience individuals were well represented in that group as in any others. You might wonder what the representation of the Royal College was. There were none in the executive and 5 overall in the different groups. And one benefit of Scott that we discovered as a college quite quickly was that it forced us to formalize something that had always been done in a very ad hoc way. The governments and the commission and various other bodies had often asked the college for views, and there's no point going to our national college for that, because our national college won't have the first idea what's going on in Scottish mental health law. And we tended to respond by small ad hoc groups to particular pieces of legislation, to particular questions. And responding to the Scott Review pushed us into establishing a permanent legislative oversight forum, which I was asked to chair. And one of the things that we were very keen to do was to base our input on our advocacy for patients, but also our clinical experience. And we were keen to try to ground the aspirations in particular clinical experiences and test them as to how they would work in the real world. And one part of that was we had a number of scenario events where we generated real world clinical situations to test out various proposals against. But I want to go on to mention some of the themes that came out over the many meetings of the Involuntary Care and Treatment or Compulsion Group, which, thanks to the coronavirus pandemic that was undergoing, took place completely online. Next slide, please. And this was, I was involved in 2 of the Scott Review groups. One was this and one was the AWI group. And the AWI group was quite technocratic and quite methodical. This one had a very wide range of very passionately held beliefs. Many of the people on the group had been impacted very significantly, in some cases negatively, by non-consensual treatment. And there were passionately and vociferously expressed views at the meetings that the chair had to try to pull together. And it wouldn't be ready me to pretend that I'm completely reflecting the entirety of the meeting. These are just some reflections to share with you. The patient representatives expressed considerable concern about the possible abuse of power, that handing over powers to deprive some of their liberty was open to abuse. And some felt that coercion should rarely, if ever, be justified. And some expressed the view that it was really just too dangerous ever to allow for justification. Others felt that it should be more limited than it was at present and with greater overall scrutiny. And there was quite a lot of feeling from patient representatives that one overriding power to do lots of things, including give medication, deprive liberty, do seclusion, and so on, was wrong, and that authorization should be split out, and that review should be more frequent, that any orders should be as short as possible. Carer representatives came from a slightly different angle and said that they felt that some of the services were too slow to act, that they were going along looking for intervention and finding that services were too slow. And sometimes that was resource-based, but sometimes that was unwillingness to use powers. But they expressed considerable concern about lack of alternatives. Many of them expressed the view that sometimes whenever you get a point Colin's already made, that when you got to the point where coercion was in fact used, there probably were no alternatives. But why were there no alternatives a week before, a month before, a year before? And professional representatives shared many of the concerns that the other 2 groups had, but wanted greater clarity on balance of rights. They were often faced with individuals who were at risk of death, or individuals at risk of ongoing living in human integrating treatment. They were aware of the fact that there had been situations where mental health care practitioners and the organizations employing them in the states in which they were employed had been found guilty of Article 2 and Article 3 rights. So how could they balance rights if there was to be any further restriction or any further change on the availability of those powers? There was, I think, relative consensus on the need to consider the development of alternatives to detention and the need for greater scrutiny across the board. One thing that did come up, which seemed superficially attractive but was much less so, was that one maybe should only intervene if there was objection, and that might seem to narrow down the number of people subject to coercive treatment. The problem with that was you then ended up with people who raised no objections whatsoever, got no possible scrutiny or oversight from the law. And so what you'd done is you'd abandoned with the law that group of people least able to speak up for themselves. And so that was one of those ideas that was initially floated, examined, and then found wanting. And it was the job of the executive to find recommendations which reflected those very diverse views. And John Scott didn't attend all of the compulsion group meetings, but he came to one or two. And one of the things he did at one point was focus us down very considerably. He said, well, look, maybe we're at a fork in the road. Maybe we need to decide whether there should be any compulsion in Scots law at all or no compulsion. And if there's no compulsion, then, you know, that's the end of that. And all we need to do is decide what we do in emergency situations. If we decide there should be a compulsion, then we're into in what circumstances, what rights should apply, what oversight, and so on. And somewhat to my surprise, when John Scott went round the group, every member of the compulsion group agreed that there were at least some circumstances in which compulsory treatment, non-consensual treatment could be applied. Although, as I said, some of the people involved described it in extremely narrow terms. But there was consensus on that view, albeit with a very different threshold on what people would apply. But as I said, John and the other members of the executive had to find recommendations which reflected those diverse views. And you've had the report in your hands since last September. It's 955 pages, 202 recommendations, but each chapter had a different number of recommendations, sometimes just a handful, sometimes a lot. But the biggest single number of recommendations for a chapter was chapter 9, the chapter on coercion. Next slide, please. Can't, in the small amount of time I've got, go through all of the recommendations, nor would you want me to, but I have broken down the 25 specific recommendations into different types. The overarching one was 9.1. We recommended the Scottish Government should make reduction of coercion a national priority over a number of years. But scrutiny, increased scrutiny of any coercive practice which did go on, had the largest number of recommendations. Suggestions for legislative review, largely, rather than specific recommendations for change, were the second largest. Standard setting and guidance to best practice, often through the authority of the Mental Health Commission, and then 4 of them related to picking up alternatives to coercion. And so what you don't have here is a draft bill or even a draft programme of action. What you've got is a series of recommendations that the Scottish Government is looking at and will decide how to progress. But not all of them rely on legislative change. Many of them rely on guidance and practice to realise their effect. Next slide, please, and final slide, please. So the Scottish Government response is due within a week. The Minister will respond to the Scott Review on the 28th of June 2023, and I'm as excited as everybody else to hear what will be said. But we got a sneak peek by civil servants about a month ago, although they didn't obviously want to bind the hands of their minister, but they thought in this area that the focus was likely to be on review, data collection, monitoring, research, policy development, and consideration of early intervention and prevention, but that the aim would be, as 9.1 had stated, to reduce coercion and use of restrictive practices such as seclusion and restraint over time. And that over time is important. That over time phrasing is important. Change in this area is a process rather than an event. And it's collaborative, we hope, rather than imposed. It's up to all of us involved in the care of patients to remain involved so that our laws and our practices really do reflect our values as a society. Thank you.
Thank you very much, Roger. Sorry about the delay there. I mean, it's very interesting to hear that kind of background and the process behind it and some of those discussions that were had. So really, really helpful to hear that on the back of Colin's talk as well. Before we move on, we are seeing some questions come up in the chat. Keen for people to continue to add to those during the next talk. Just maybe to say to people, the questions that are brought up in the chat box are not part of the recording, so people can feel free to add questions to chat as well. That brings us on to our third talk, which is from Claire Lamza. And I guess it's picking up that challenge of, we've heard a lot about the background, we've heard a lot around the responses, but and challenges in the talks from both Colin and Roger as to how we put that theory into practice. So that brings us nicely on to Claire's presentation about what will coercion and these new kind of landscapes mean for us in clinical practice. So I'll hand you over to Claire.
Thank you, Jane. It's just, as Colin highlighted, from a perspective of what language would look like, and I think from Roger's point about how we get that balance. As someone that works for one of the organisations that has a number of recommendations levied at, along with another group of organisations, all of the ones that look at the scrutiny, regulatory, the inspection landscape, coercion really absolutely brings a challenge for us all in thinking, how will we do this? How will we look at what's happening out in the practice landscape? And in the actual chapter, there's a really lovely part from the Scottish Human Rights Commission who talk about focusing on these actions can actually set Scotland on a very practical path to eradicating coercion. And some of the contributors to the review said what an enormous challenge. But again, I think the review sets some really easier to put into place options with what we can start tackling, as it does in a number of particular chapters. Next slide, please. So the issue for us is about getting our heads around this term of coercion, and as Colin said right at the start of it, it's not one that will sit very well with practice. As somebody that works for an organisation that goes out and challenges language through the different ways that we do, but also as a nurse, there are a range of things that when we start talking to people about coercive practice, you can see things that like hackles might rise. People might at that point, the prejudices, the judgments, and possibly the defensiveness that comes from that terminology will very quickly set a barrier, we think, in terms of people not being able to dig down into it and figure out what's at the back of this. So while, understandably, terminology such as restricted practice could be considered, actually calling it what it is, calling it coercion, opens a door for people to be able to understand, well, if this is what I'm doing, how can I do something different? If this is what's happening to me, how can I engage with other practitioners, or how can I engage with individuals with lived experience, or their carers, their unpaid carers, to be able to make improvements around about this? To go back to what the HCA, the Scottish Human Rights, said, it's the eradication, or at least reducing this over the period of time, which, as Colin said, is a national priority. So the review set out what I see as a practitioner, a really clear way of starting that process. And it gives it in an explanation which talks around about from voluntary to non-voluntary, all the way through to the formal coercion end. And I'm going to talk a little bit about that as the slides go on. But it's that series of steps that happens and being able to understand them for practitioners, but actually making that language communicable, understandable, visible, clear for individuals with lived experience, so that when this is happening, there's a clarity with what's going on, and an opportunity at that point to say why, an opportunity at that point to disagree with it, an opportunity at that point to figure out, should something else be done? And I think that's part and parcel of the overall objective. And for us, it's that part in the commission of thinking around about, well, we already, when the 2003 Act came in, started on a rights-based approach with the legal frameworks that we had. And it's enhancing those, because we know it's not working in practice in certain ways. We know, as Colin said, that revocations of short-term detentions, they could just run their course. We know that the use of pharmacological interventions is a key priority, and we use T2s and T3s to do that, but we're maybe not using things like social prescribing. So for us, it's thinking around about how can we start implementing those strategies that then move away from what could be considered restrictive or more restrictive or coercive practice. Next slide, please. And as I've said, that flow that we can see through this whole series of steps may actually be useful in terms of on the shop floor, at the grassroots, and in any setting. Colin talked earlier on about the inpatient setting in health, but there's also so many opportunities to look at this. The National Care Service Bill that's coming through could look at this more clearly. The independent sector, not to mention advocacy services, the different approaches that support. I'll come on to that little part about what's happening in terms of the peer group community, making sure that that side of the way that people are supported when coercion is applied gives us opportunities to do things differently. So I think, as in all things, moving through the rough end of the stick is the formal coercion, but the clarity that can come from that, if we're doing this better, if we're doing this more clearly, if we're doing this more in partnership, I think at that point it may be easier to come back down the scale than it is at the moment. What we find is it's very quick and very speedily moved up the scale, but maybe not necessarily in the other direction. So that whole way of looking at it from what's happening in each category that could be considered coercive practice might allow us then, as we put in place the tools or the approaches or the range of interventions that could be done to actually assess where coercion's being used, how it's being used, and what we can do to prevent that or reduce it. Next slide, please. So I couldn't not have an opportunity to talk about the Mental Welfare Commission in this slide. It's more to be able to say that when it comes to this part, as we've got a number of categories, a number of recommendations that can be used to do it. And I think there's always a bit of a clarification or a caveat that I do with any discussion, is that the Commission is a very small organisation. There is one area coordinator for a lot of the health and social care partnerships. Sometimes we're really lucky when the bigger ones like Glasgow or Edinburgh, there's possibly 2 or 3. So when you look at our statutory duties as they are at the moment, and then to add this on top of it, the Commission is very clear that resourcing and funding, as it is, I think, across the whole piece for this particular chapter, will be required. But even at this stage, if we're thinking about what can we do that's better, what can we do that has more clarity, what can we do in terms of some of our powers around about information advice, our visiting role, we can already be picking up some of the ideas. And I think Roger talked about some quick fixes and some quick things that you can do without having to wait for the legislative framework that comes in at the back of this. So when we're out and we're already starting thinking about how do we access community mental health services, how do we access learning and disability teams, how do we access those environments that at the moment are Health Improvement Scotland's domain or the care inspectorates, where individuals are sitting under very formal legislation, whether it's a guardianship order or it's a compulsory treatment order that's been varied to the community. How do we then look at what's happening in terms of the level of coercion? And part of our visiting programme already picks up when that happens. We already have sections where we look at the legislation, what's being used in terms of specified persons. So there's real opportunities through our visiting element. We annually report on the parts of the Act in terms of the Mental Health Act, EWI, Children and Young People, Advanced Statement Overrides, all of the things that we can then start being a little bit more focused on. I think Colin talked about some of the groups where there's higher levels of use of acts or legislation and how that can be focused on. And we've already done a theme visit that looked at the group from ethnic minorities and the higher use of particularly Mental Health Act at that point. So there are real opportunities when we're looking at the monitoring of these acts to start looking at where the coercion elements there, what happened when someone was made a specified person, what happened when there was an advanced statement override. So those are discussions that we can have with the care providers, with the practitioners in the service, to really start embedding that conversation around about what's happening in relation to coercion. And investigations which we already do in terms of particularly Mental Health Act and AWI, and more recently the ones that are coming through in terms of adult protection, will give us an opportunity to highlight some of the lessons, some of the key findings, but also some of the recommendations that we can put back to areas where this has happened, whether it's health and social care partnerships, whether it's the independent sector, whether it's through our advocacy reports that we publish on. There's lots of opportunities for us in working alongside to be able to try and support different ways of addressing this, and the armoury that could be done in terms of different approaches and that basket of different ways of looking at coercion and how to tackle it. And we have a very actively used advice line, so often that allows practitioners to call in and say, this is happening, how do we do this, how do we change it? So again, using these methods from the Commission's perspective would allow that opportunity for dialogue, conversation, structure, thinking about change, and that comes through with our good practice guidance. It comes through with our forums that we are attending, like this one, like the joint meetings that we have in terms of whether it's Social Work Scotland, whether it's Mental Health Nurses Forum, whether it's the Royal College. All of these promote opportunities for discussion and looking at ways that different approaches can be used. Next slide, please. So the big crux of all of this is, how do we get into that area where we actually know what is coercive practice? And the flow chart that took us through that, the one that where we moved from the voluntary all the way through to the non-voluntary and the formal, the key end that causes so much angst that we really have to start thinking about without getting defensive, without our hackles going up that part, is looking at the parts that are probably more informally done, that are happening on a day-to-day basis. And having been a registered nurse in inpatient and community settings, I've seen a lot of this just as it happens in custom and practice. But that part where blanket restrictions generally start to come in because it's a good idea, or it's seen as a good idea to have some clarity around about it. That sense of, if there's a locked door, what would we do with that? If you're working in an eating disorder unit, how do you then make sure that someone follows the process so that they're getting better, they're improving, that the things are happening in terms of what they need to have access to? If somebody can be on an outing or get out of the ward or do something, but that has to tie in with risk assessment. At that point, one has to start thinking about how much coercion is being used. When someone goes to the door, and I think about this from the nurse's power to detain, when someone goes to the door, what are we using at that point in terms of having a conversation? How much of that might be the informal coercion approach? And the other strand to all of this is thinking about where physical, psychological and cultural environments actually reflect what we then get into having to use as a process of engaging people, and how much that moves us into coercion. And one of the parts that the chapter talks about is the Maggie-centred-esque type environment, where these purpose-built, beautifully maintained but very well developed services in the right environment, with the right methodology, with the right care and treatment round about them, actually then, what would be the requirement for coercion? Would it need to be used at that point at all? Because people are in a setting with the right treatment teams round about them, with the breadth of approaches that can be used, that coercion actually is on a sliding scale anyway, because it's not required. And the other part of roundabout informal, and we get so used to it because culturally medication and the route for medication is seen as being something that that's the starter for 10. But when we look at other alternatives, the non-pharmacological, the non-medical alternatives that are around to medicine, the different approaches that we're now using in terms of dementia, the different ones that we've tried to develop in terms of adult acute settings, where we looked at social prescribing, those that then transfer out to community-based services, or to the social care settings, all of those would, if they were in place, if they were resourced, if they were funded, could actually have such an impact on this particular strategy. But the formal ones that we've already highlighted in terms of restraint and seclusion, there's significant amount of work to be done. And while there is no specific legislation around about it, there are already some structures that would make it not such a leap to be able to get to that. And again, it's one of the recommendations, I think, in this particular chapter, is that the scrutiny and monitoring that goes behind that. Many organisations don't even have a seclusion policy. Some of them, in terms of seclusion, there's no clarity around about what would be seclusion, what would be segregation. We've heard that being used, what would be isolation. So the clarity around about these formal measures that are being used that are coercive needs better understanding, needs better guidance, needs better monitoring and scrutiny. And then it takes us down to how the legislation is used, who's been informed in it. The law review talks about the use of will and preference. We're already finding that it's difficult to get individuals to develop advanced statements. But however, if we don't start at that end of it, where people are aware of what they would want happening to them if they were admitted to hospital, how can we then develop that on and make sure that we are monitoring even more closely the use of coercion and what happens to an individual when it's the most formal end of the spectrum? And the role of the DMPs, there are some questions about whether, I think the first question that we're probably finding at the Commission is that increasingly it's very difficult to get DMPs. So actually one of the options that's raised in the review is, could that DMP role be extended? We have psychologists that are very well skilled, trained at a very high level, and Colin talked about the trauma-informed practice and that particular way of understanding it, which being so useful in terms of understanding coercion. The other aspect is there are nurse consultants who are, or advanced nurse practitioners who are working in these settings, who understand the complexities between the interface of somebody's illness and what happens as a result of that. So the opportunity to look at what DMPs, or who sits in the D, possibly not the M part, but the P part, and then their particular responsibilities is useful to think about. And finally, the monitoring and scrutiny. And I said at the start, we already do a fair bit at the Commission, but in order to do this and take this to the next level where we are actually identifying what is coercive practice and to the extent that it is, and then the lessons from that will require funding, will require resources, but it'll also require us being able to be out with the services, with practitioners, being able to explain that a bit more in detail so that they can start making changes according to what we're looking for. Next slide, please. And I've only started with a few of them. I'm mindful we've got 15 minutes, but as I've said, the Commission has, there are a number of recommendations for the Commission, and we're really keen working alongside our partners in terms of Health Improvement Scotland, the Care Inspectorate, our connections with advocacy organisations, our E&P officers, to start thinking about how we would then address coercion. And I've only picked the top ones, and then I've given the huge one at the bottom, which will cause significant challenges to all of us. But if you think about what we've already got in place and how not such a big leap it is, but the structures round about it, the processes round about it, the interventions, the approaches, all of that can be adapted without too much difficulty, I suspect. And if you're looking at the first three, the one-to-one meetings, the peer support workers, the legal representation, proxy decision makers, whether that's guardians, whether it's MHOs, key workers, nurses, independent sector, all of that group that could then start making the difference in terms of that sense of belonging, the connection and the trust in societies, which probably is quite a difficult one to get to. But when I started thinking about from this, all of these infrastructures are available and around. They require better resourcing, they absolutely require more funding, and probably of a longer duration instead of the 2 and 3 years. It's the same with carer support groups, community meetings, whether that would be in an inpatient or a community-based settings. All of these have the opportunity to look at activities that could be used to address coercions. But the other part of it, and it's across every service, is the formal documentation processes. And you'll see I put care plans there and the ... because it's one of the things that the Commission does so repeatedly, as do our partners in Health Improvement Scotland and the Care Inspectorate. And they think about what is a person-centred care plan? What would a care plan that looked like that actually highlighted coercion was used? And again, that's not out with the realms of possibilities in terms of when we're writing about somebody who's been made a specified person, or we're writing about somebody whose risk assessment meant that they couldn't leave the environment unless they were in a 2-to-1 or whatever. There's opportunities within all of these settings, and case reviews, multi-professional meetings, CPA if you're really lucky in some areas, all happen in both the health and the social care settings. So there's real opportunities at this point for us to start looking at it as practitioners. Formulation settings goes back to the thing, if we then start having psychologists who follow that role of designated practitioners, then that whole tie-in between what they do and the understanding and the education and the challenge to coercive practice could very then quickly fall through to the latter part for a lot of us in terms of understanding it through reflective practice and clinical supervision. But the last one, and ending on possibly more of a challenging note, is the training, education, resources and funding that will be needed in terms of doing this, and how we can start doing the part around building the research that's required to be able to identify what these approaches will be, the implementation of these, and Roger talked about us eagerly awaiting the June 21st from the Scottish Government. But behind all of that is our opportunity to influence and shape and make sure that what we've got from an education, whether it's the pre-reg part or whether it's all the way through to part of an induction programme that can be in any service at any time. But that absolutely will require thinking about where the resources will come from, the expertise and the knowledge. And this is starting that journey for us all. You all here are already thinking about, how do I get my head around coercion? So to some extent, the resources are building, and the commitment to this. But the funding, as we've said in so many things, will probably need to follow. And again, I think that's the challenge taken back to Scottish Government. And that's it from me. Thank you very much.
Wow, amazing, Claire. I think that nicely summarises a lot of where we're going to be around bringing this from the page and into practice, and some of the challenges that we face. There's a pile of questions which I hope we can do justice to. And the first thing to say is apologies if anyone feels their question isn't